Okay, and welcome to the Davies Use Case webinar being presented by Atrium Health on reducing readmission. This is a Davies Award-winning use case for the value of health IT. My name is Arnold Simmons, and I'm the manager at HIMSS on the thought leadership team. It's my pleasure to moderate this presentation. Core to the HIMSS mission is promoting the use of health information and technology to improve the quality of healthcare delivery. HIMSS promotes and advocates the integration of clinical decision support and best practice guidance, access to clinical data to analyze progress, and information and technology-enabled patient safety tools for all healthcare organizations, clinicians, patients, and community members as vehicles for improving patient outcomes. The HIMSS Nicholas E. Davies Award of Excellence is the pinnacle of the HIMSS Value Recognition Program. Davies Award recognizes outstanding achievement of organizations from around the world who have utilized health information and technology to improve patient outcomes and value. The Davies Award-winning use cases have been peer-reviewed to validate sustainable, improved patient and business outcomes resulting from health information and technology-enabled care delivery. So it's my pleasure to welcome our speakers from Atrium Health today. We have with us Ruth Krystopolsky, who's the Senior Vice President of Population Health for Atrium. And we also have Dr. Stephanie Murphy, who serves as the Medical Director of Atrium Health Transition Services and also Co-Medical Director of Atrium Community Paramedicine Program. So let's welcome them both to the presentation today, and begin when you're ready, and thank you for joining us.
Thank you, Arnold. Very pleased to be here today to speak specifically about work that we are doing at Atrium Health and how technology is helping us not only identify patients that we can intervene on, but also assist us in automating workflows and interventions so that we can use our resources more efficiently. I'd first like to take a moment or two and let everyone know who Atrium is. And in order to do that, we often go back to the roots of the organization. And in the 1930s, a group of individuals got together in the Charlotte area and really rallied in order to improve the services that were available to the public and the people that were being served here, and built Charlotte Memorial Hospital. And the intent was that the building would not be private, and that we would serve the public. And through the years, that mission of serving all in our communities continues onward. Today, Atrium Health, starting from Charlotte Memorial Hospital, has grown across the North, South Carolina, and Georgia regions, and represents an opportunity to care for people in our communities. Wanted to spend a minute reviewing our mission, really, which is to improve health, elevate hope, and advance healing, again, for all of those in our communities, and to be the first and best choice for healthcare for the region that we serve. Sometimes scale is interesting as we start to think about how do we use technology to help us across a really broad footprint, and we'd like to tell folks what we do in a single day at Atrium. And so every day we encounter more than 37,000 patients. We have more than 90 babies delivered across our footprint, see 25,000 patients in our physician offices, and provide $5.6 million in uncompensated care and other benefits to our community. That's each and every day Atrium provides those resources across the Southeast. We're served by nearly 70,000 teammates in 50 hospitals and over 900 care locations, and invest and reinvest in our communities to the tune of almost $3 billion in the last 5 years in renovations, additional services, and upgrading the facilities that we use to care for our patients and the technology that we use in order to do our work every day. And so from the humble beginnings in 1940 of the Charlotte Memorial Hospital, you can see that we've grown across the region and have provided access points to the broader Southeast market with the commitments and the intent to care for all people in our communities. We are the largest Medicaid provider in North Carolina, and out of the 60,000 hospitals in the country, we're number 19 in providing free and uncompensated care to our communities. And so our For All mission really has driven us to think about how do we continue to do well in the community in order to continue to have the capacity and ability to serve all of those people who need us. Now, like many other healthcare organizations, we love to be recognized for the work that we do, and whether it is being a best place to work for women and one of the leaders in employment from a diversity standpoint, to being most wired. Atrium Health consistently scores and ranks well in the recognition areas that most healthcare organizations are focused on. And so that's a little bit about who we are, and what I want to specifically talk to you from a population health lens is a local problem that we have, and I believe many healthcare organizations have, and that is the problem of inappropriate use or overuse, and in this case, readmissions. And again, with 50 hospitals and a broad footprint, being able to identify individuals who are at risk and then intervene from a readmission standpoint is not only a patient care imperative, it has huge capital and financial implications. And in order to do that, several years ago, we did invest in creating visibility across the broader population by working with Cerner to use the Healthy Intent platform. And we are a Cerner, mostly Cerner EMR entity, but we have a variety of partner organizations that use other technology, and we're really looking for a platform-agnostic way to bring data from across the footprint together so that we could aggregate and normalize it, and then create and apply intelligence so that we had visibility into who we should act on. And then finally, measuring our performance on a consistent basis to make sure that the interventions that we were doing were actually working and moving the needle on our populations. And so I always like to start my talks with a particular patient, because I think patient stories help us understand not just opportunities, but how interventions and data come together in order to help guide our work, and where we can have a meaningful impact on both process, but more importantly, on the outcomes for patients. So I want to introduce everyone to Joe. Joe is Atrium Health's highest emergency department utilizer, and as a matter of fact, over the past 4 years now, Joe had more than 1,500 emergency room visits. And as a matter of fact, as we started this project in the first quarter of 2018, Joe had already had 104 emergency department visits in the first 120 days. And while that seems interesting, only to be beaten by the fact that the other 16 days of the 120 days, he was actually an inpatient or in observation status in our facility. And Joe had, just in facility charges, accrued over $1.5 million between 2015 and 2017, and was well on track for 2018 on increasing that. And so we were providing excellent health care services to Joe each and every time he came. As a matter of fact, if you pull his medical records, you'll see that for those 1,500 times he was in our system, we did exactly what was clinically relevant and right. And yet we were not meeting Joe's needs. And so Joe was 36 years old. Joe had a variety of medical conditions. Most importantly, Joe had post-traumatic stress disorder as a result of a childhood surgery on his heart that made it almost impossible for Joe to be far enough away from the emergency department, because as he got anxious, his heart would race, he would think that he was having another heart issue, and then would check himself into the ED. We brought this data visible and in front of our teams and decided that we needed to intervene on individuals like Joe and put care team meetings together, worked on obtaining housing for Joe, getting him appropriate behavioral health therapy, as well as access to a primary care provider, and actually have a community paramedicine person who visits him. And as of this past month, Joe has only had 39 emergency department visits since June of last year. So an absolute success story for Joe. And as a result of this success, we've actually enrolled an additional 84 patients in a program and have saved in excess of $1 million for emergency department charges and decreased hospital and ED utilization for this population over 2018 by 55%. And we're enrolling more folks into the program. None of this would have been possible without the aggregation of data and interventions at the Healthy Intent platform level, and then serving this information up into workflows of our care managers, both on the floors and in the ED, as well as allowing us to measure and monitor progress across the broader system. And so as we look at an individual like Joe, we start to ask questions: can we scale these programs across the broader Atrium footprint? And so we did work on a project in 2018 across the entire Atrium footprint, looking at the highest ED utilizers, defining plans at each level to connect them to the appropriate care, and then understanding issues that they might have in order to address any kind of social determinant of health issues, and then engage them. And our outcomes have been, I would say, staggering. And so for the patient cohort that we had for 2018 that had more than 20 visits, we reduced their actual visits across the year by 40% and reduced the charges for this patient population by 39%, which scaled up across the Atrium footprint is about $16.6 million in charges reduced. And some of the folks that have used the ED the most are not, so we've created capacity for patients who actually need the emergency department. to address their issues. So as we start to think about patients that are not intersecting with the healthcare system correctly, we've spent a lot of time, and Dr. Murphy will talk to you about a robust structure that we've put around readmissions and significant interventions that we've done in order to improve our performance. And we have year-over-year performance improvement, but the improvement was beginning to slow. And so a team got together and actually looked at our highest multi-visit patients. So those individuals that had high readmissions and high admission numbers. And what we found was for our 600 top patients across our 50 facilities, they represented 46% of all readmissions. And so could we do a similar process with defining a plan, intervening, and then impacting both admissions and readmissions for this patient population? And over the first 6 months of 2019, we began the project in January. What we've seen is a similar reduction in actual number of inpatient visits, about 38%. And about a 27% reduction in spend. And for our organization where we have capacity constraints on a regular basis, this has represented about 2,430 fewer bed days in the first 6 months, creating capacity, again, for individuals that we need access for within our inpatient settings. So another focus on using data to drive interventions at these highest need patients, driving significant performance improvement with the information. One final thing I'd like to speak to is the capacity and ability to really automate processes that had historically required a lot of intervention. And quite frankly, we weren't doing well. We weren't doing consistently, and we were actually using nursing staff to do. And that was a post-discharge hospital follow-up with primary care. And so we spent the last number of years studying interventions on our patient population, and what we found was there was a statistically significant improvement in readmission rates, quite frankly, by more than 60%, for those individuals who had a scheduled primary care visit upon discharge and actually attended the visit. And so we risk stratify all of our patients using Cerner technology into high, moderate, and low risk for readmission. And we had historically had nurses in the units attempting to schedule primary care office visits for those folks as they were being discharged in order to help prevent them from returning to the hospital. One of the challenges that we had was most of our nursing staffs in the acute care facilities did not know how to use the scheduling system for outpatient appointments. It was one thing that was getting in their way of getting a patient discharged and out of the bed, and we were failing miserably in both getting the patients scheduled and, quite frankly, having the patients actually show up for the appointments that were scheduled. So over a period of 18 months, we hardwired a process that was done through a discharge order set in the Cerner platform that pushed as part of a discharge summary, a discharge order, a request for an appointment with the patient's preferred time of day and day of week with their primary care provider to our patient appointment scheduling center, who then completed the appointment, routed that back through the discharge summary to the clinical teams on the floors, and then followed up with a text message to the patient confirming the appointment. And for those that did not respond to the confirm, we actually did a robocall out. And for those that did not respond to the robocall, we would then do an actual outbound phone call. And what we found was we went from scheduling less than 20% of the patients who were leaving to closer to 70 to 80% had their appointments scheduled, and having, again, less than a 20% show rate for those patients with appointments, close to an 80% show rate. And so we continue to see improvement in readmissions based on hardwiring and automating processes that historically had been done manually and done with the wrong staff in the wrong place, and quite frankly, not meeting the patient's needs. So a real win in that space. And so we have done a whole host of interventions that we continue to measure and monitor that are looking at preventing readmissions for our patients, all payers across all of our facilities. And many of these interventions have assisted in the continued improvement. And so now I'm going to turn the talk over to Dr. Stephanie Murphy, and she's going to talk specifically about why we're focused on readmissions and then how some of these interventions have improved outcomes for our patients.
Thank you, Ruth. So the question of why readmissions, why did Atrium Health focus on readmissions as a problem within our system? What we realized as a healthcare system is that 18% of Medicare patients discharged from the hospital have a readmission within 30 days of discharge. This is accounting for $15 billion worth of spending. Not only did we realize this, but Medicare and other payers have started to realize this, and subsequently have started to create metrics both within insurance contracting, looking at the hospital reduction in readmission policy, and then recognizing that this is also one of the most significant drivers in higher patient costs. Ultimately, though, what we realized at Atrium Health is that readmissions and focusing on this work is the right thing to do to take better care of our patients. This is a brief history of the work that Atrium Health has done with regard to readmissions. As you can see, this is something we started back in 2010. In 2015, as you can see, there's a highlighted box at the bottom of this slide. This focuses on the kickoff event for the new Readmission Strategy Committee. This is key in the work that we've been doing within Atrium Health. I'm going to highlight the build and design of this committee. So the Atrium Health Readmissions Committee structure is led by an executive team. This executive team meets monthly at our strategy team meetings. The subcomponents of the strategy team focus on readmissions in a multidisciplinary, multifaceted way. We recognize that patients who are being readmitted to the hospital are readmitted from different dispositions upon discharge from the hospital. So we engaged home health, skilled nursing facility, and rehab. We also, of course, recognize that we need to focus on the acute institutions and look at the processes happening when we're discharging. We also have leaders from emergency medicine and as well as behavioral health, because again, another acute care institution. We have three subgroups: the transitions work group, which I have the privilege of chairing, the access work group, and then the internal education and awareness group that span all of these other subgroups. So in addition to doing work directed at the transitions work group, we also work with those other subcommittees to help make their initiatives driven throughout the system. I'm going to give you an example of the team approach that's used on this strategy committee. First and foremost, all of our committees are physician-led, which is important with regard to engagement from the provider perspective into the work that we're doing. We also have an administrative co-chair who helps us navigate the system to get our work and our initiatives put through in the most effective and streamlined way. We also have a leader from quality that sits on our group to help us monitor the impact of our initiatives and to help us target our initiatives in areas where we know, based on data, that work needs to be done. The purpose of the transitions work group in particular is to reduce readmissions by efficiently improving transitions of care and specialty access across the continuum of the patient experience. As you can see, that what's in our scope is any transition of care within 30 days, and that was illustrated on that flow sheet on the previous slide, which means we do a lot of work both with home health, skilled nursing facility, rehab, et cetera, to make our work go, if you will, within the system. 80% of readmission opportunities are patients who are discharged to home or self-care, as well as with home health care. And so that's an important note, recognizing that those are often the patients who are not being followed by one subcommittee, and subsequently, again, emphasizes the fact that we need to bring multiple disciplines together to really care for these patients. Things that are out of the scope of this work group: patients who are less than 18 years of age, patients who are struggling with behavioral health access, or patients who need access to primary care, because that is followed by the access committee that was also illustrated on that flow sheet. This is an example of the success that can happen when you utilize multidisciplinary teams, as well as teams that are located in different points in the care continuum. This is a patient who was recently diagnosed with heart failure. The patient actually was discharged home with an LVAD in place. This patient was being followed by home health care very closely. The home health care nurse went out and astutely noted that the patient had a 10-pound weight gain in about 24 to 48 hours. She was able to call the provider who was responsible for this patient, who felt that the patient needed IV Lasix that unfortunately the home health nurse did not have access to at that point in time and could not obtain from the local pharmacies. Thankfully, because of a connection made through this multidisciplinary committee, the home health care team was able to reach out to the transitions partners in the paramedicine program. Our paramedics were able to see the patient that day. So this was done in a less than 24-hour period of time, which is remarkable when you think about access to care in the post-acute space. They went to the patient's home, administered 80 milligrams of IV Lasix. They handed the patient back off to the home health team for ongoing monitoring, and they were able to stave off a hospital readmission. Another initiative that has been launched through Atrium Health is a transition services clinic, which I have the joy of overseeing. A transitions clinic, in this case, is a multidisciplinary approach to care. We go beyond traditional medical office visits, and ultimately what this is an integrated practice unit. We focus on discovering the root for the patient's failure in our current healthcare system. We try to support and alleviate those causes, while in addition managing their disease state or their multiple disease states that have often led to their hospital readmissions. We do this by education. We do this by management of complications of those illnesses, as well as any sort of subacute needs that occur during their time in the clinic. We are integrated with behavioral health as well as palliative care so that we can support this patient in a multidisciplinary and comprehensive way. We offer a unique care delivery model. We recognize that not all patients are able to do in-office visits, so we have virtual visits. We also work with our community paramedicine partners to support those patients in their homes, recognizing that that may be their barrier to care and why they are failing in our current healthcare system. Our clinic is rooted in research and quality, and I will get into that data as we move forward with the presentation. As you can see in the right bottom corner, there have been 990 patient enrollments in 2018, and there were over 2,500 patient encounters within our clinic. When we started the Transition Services Clinic, we knew that we needed to use big data to be able to target our patient population. We recognized that an intervention of this magnitude and of this cost needed to sustain a return on investment as well as accurately measure success. In looking at the patient selection, we were able to validate readmission risk factors to develop a criteria for both our providers as well as to create a tool that would filter patients appropriate for our service. We looked at patients who had greater than 4 inpatient encounters in the last 6 months, 10 chronic medications or more, greater than 15 medical problems, or greater than 4 emergency department visits in 6 months. Recognize that this is not an all-encompassing list. If the patient had any of these risk factors, we recognized that would increase their risk for readmission. At the time, our system was utilizing a prediction risk score for inpatient admissions to help us determine very high, moderate, and low risk patients. So utilizing a prediction risk score of greater than 0.8 would give us patients that were high and very high. We continue to use data as we evaluate the patients that are appropriate for this service. This system has transitioned, as I stated previously, from prediction to what's called the Cerner risk score, which is embedded in our electronic medical record. We target high and moderate risk patients. We've also recognized through our data and quality improvement work that there are new patient populations that require support of this magnitude. Patients that have disease-specific issues such as sepsis that immediately put them at a higher risk for readmission. And subsequently, we've been able to create new initiatives throughout the system. We also need to utilize data to ensure that we are maintaining our impact throughout the system. We utilize people in the transition clinic. As I stated at the beginning and the summary of our work, we are a multidisciplinary clinic, in essence an integrated practice unit. So what do these patients experience when they come to our clinic? Well, first of all patients are met by a pharmacist and a social worker as well as a medical provider, be it a physician or an APP. They also have access to a care manager, RN/navigator. This provider meets the patient in the hospital and helps bridge that care into our clinic to make sure that all of their needs are being met. We have a referral coordinator who helps to streamline subspecialty follow-up as well as any sort of testing that needs to occur during that post-hospitalization, post-acute time frame. As I stated previously, we are integrated with palliative medicine as well as behavioral health. Every patient on admission to the transition clinic has a PHQ-9 performed, recognizing that untreated depression in and of itself is a risk factor for readmission. Subsequently, when we do have scores greater than 9, we offer those patients a virtual behavioral health integration consult so that we are able to start treating that independent risk factor early and regularly throughout their time with us. We have a health advocate who helps these patients navigate the healthcare system telephonically, and of course, we have community paramedicine, which is key to our ability to bridge gaps in care for patients. What's the process for the Transition Services Clinic? This is asked of me frequently, and I apologize for the wordiness of this slide. Ultimately, high-risk patients receive a referral to the Transition Services Clinic either by an inpatient provider directly or via automated tool that is embedded in Cerner. The automated tool that is running in the background takes into account all of those risk factors that we talked about on that first slide with regard to data. This is working every day. We get an automated list delivered to us every morning of patients, both direct physician referral or referrals or referrals. The patient in the hospital by our care manager navigator. She's able to talk to patients about barriers to care, the reason for the clinic referral, and also mitigate any barriers the patient may have in making those follow-up appointments. We see our patients within 72 hours of discharge, and we do that in a myriad of ways, all of which leverage technology as well as bridging care gaps. We will offer patients community paramedicine visits where they're seen in their home. At that time, if necessary, we can provide a telemedicine visit with a provider, or we will see patients in the traditional in-clinic setting. As I stated previously, every patient gets that PHQ-9 screening so that we can start treatment and intervention with any behavioral health need early and often. They get a comprehensive medication review by our pharmacists who offer recommendations to our providers with regard to any medications that may be meeting Beers criteria concerns, dosing concerns, etc. And then, of course, probably the biggest impact that we can make in a lot of these patients' lives is assessing their social determinants of health, and that is where our social worker gets involved in every patient. She ties these patients to community resources, assesses emotional needs and coping, as well as their support systems in their home, as well as physical supports, as you can see. Utilization of process. This is key in the work that we're doing. We need to have a patient-centered focus to our care, and as you can see, this is a loop. We expand the boundaries of care, we improve those care transitions, we educate patients about their conditions with an integrated approach, and subsequently we take our visits to the patients. Because of this circle of care, we recognize that we can improve overall care transitions, but also overall health for our patients into the future. We utilize health IT. As you guys have seen throughout this presentation, we're utilizing data and informatics in all of the work that we do in transition of care, from our patient selection to how we receive our referrals to how we deliver our health care with the utilization of virtual care. On the back end, we also utilize analytics to be able to make sure we're maintaining our impact in our patient population. These are screenshots of what the transition of care referral looks like within our electronic medical record. As you can see, it is visible both to the transition services team as well as to the attending provider. This is another screenshot of how you make a list in Cerner. And so what we are able to do is create a patient group so that our navigator care manager RN is able to keep her workflow within our electronic medical record, as well as her documentation and communication to the inpatient and outpatient providers that this patient has accepted our service. As I stated at the beginning of the discussion about the transition clinic, we had to know which patients would benefit from this service so that we could maintain our impact in our healthcare patient population and our return on healthcare investment. We had 990 patient enrollments in the year of 2018 and just over 2,600 patient encounters. This is a shot of our virtual care and the system that we utilize to deliver that care. We utilize the video desktop. There is a headset and microphone so that I am able to link in utilizing a stethoscope technology to listen to heart and lung sounds while the patient is in their home. Our paramedics also have a high-def camera so that we can look closer at wounds and other issues that may develop for the patient. Looking at Atrium Analytics. We utilize analytics in a myriad of ways here at Atrium. As you can see in the bottom right-hand corner, we like to use heat maps so that we can look at readmissions by location. We also look at things like day of discharge, timing of those readmissions within 30 days, within 60 days, within 90 days. And then, of course, the diagnoses and clusters of diagnoses that are leading to readmissions. This allows us to target our work not only to right care location, but to right care facility and to the right type of patient population. We utilize dashboards to be able to give feedback not only to the providers, but also to the facilities, to skilled nursing facilities, to the acute care facilities, and we can drill all the way down to certain diagnoses to be able to give our providers and our teams feedback to know how we're doing in real time. Analytics drives improvement, this much we know. By utilizing our analytics at Atrium Health, as I stated, we're able to figure out different populations that require different levels of care to impact the metrics and the overall patient care. We've been able to launch a sepsis and infected population readmission work based on the analytics that we have, as well as day of discharge, so Monday discharges, and 0 to 3, 5, and 7-day readmissions because of the analytics that we've obtained. We are value-driven at Atrium Health, we have no doubt. Because of our strategy committee, we've been able to monitor the value and the impact in observed to expected ratios and compare ourselves not only from a metro area to a regional area, but also to the national average and work to drive ourselves toward the national top quartile and top decile. This is a disease-specific evaluation of the work that we're doing in the metro area at Atrium. As you can see, the work that we're doing is gradually driving that readmission rate down. This is heart failure, solid tumor, malignant hematology, and sickle cell. Sickle cell is a very difficult diagnosis nationwide, and looking at the work and the constant downward trend that has been put in by Atrium Health, it's very telling the results that you can get in a diagnosis that previously was seen as very difficult to impact. It can be done. It just takes a coordinated and multidisciplinary effort. Fantastic work. The sickle cell team, as well as the Transition Services Clinic, were highlighted at our Quality and Sharing Day at Atrium Health. Currently, there have been over 39 patients with sickle cell disease that have started following up in our Transition Clinic. What we did to start this initiative was we trained our advanced practitioner with our sickle cell team to be able to bridge that gap for these patients. Again, we've enrolled these patients in the multidisciplinary program, but in addition to that, have offered them specific sickle cell dedicated education as well as disease state management for these first 30 days. Our practitioner works in conjunction with our sickle cell specialty hematologists, and the proof is in the pudding. We've reduced readmissions from 23.7% down to 15.27%. So 35.5% reduction in a very short period of time. What are some lessons learned from all of the work that we're doing at Atrium Health? Well, what we've learned is that analytically driven, personalized care delivers not only value, but it also improves your return on investment. We must identify high-risk patients early and begin their transition upon admission to the hospital. We can't wait until the end of the game to get involved in these patients' lives. We must get involved on admission and build on the lessons learned into the post-acute space to continue to grow these patients both with education, disease state awareness, and give them the ability to take care of themselves. But at the same time, we need to be able to recognize that subacute needs are going to occur and manage them in a proactive way. We need to be able to measure success factors, and those success factors need to be translated to senior leadership. And we need to make sure that we have physician leadership within that to drive home these best practices in the operations world of healthcare delivery. We have to have quality support to be able to bring that data forward in real time. And then we need to engage the patients in a full care continuum, which means that we need to have multidisciplinary committees at multiple points in time throughout our own care continuum to impact these patients. We need to make sure the work is visible. It's very important to show success, but also focus on where can we improve so that our focus stays on the patient and continued care improvement. In summary, our local problem was that we needed to close the gaps in care to reduce readmission rates. The goal to reduce readmissions focused on a multifactorial approach. It required people, it required process, it required integrated technologies and big data. The other piece to that is it required people and processes in a multidisciplinary way throughout the care continuum with one connection to be able to continue to improve work together and find gaps that we could fill together. We also needed healthcare IT to be able to keep our information within our electronic medical record so that we could communicate with each other in a real and effective way. We also knew that we needed to leverage different care delivery models to reach our patients. And then, of course, have data and analytics to know, are we successful and where do we need to improve? In summary, we have some fantastic outcomes in the work that we're doing at Atrium Health, and we've been recognized by some different national publications. Becker's published us in December of 2018. We were also recognized in Healthcare Business Insights. Our heart failure team was recognized at New Hanover. And you've already seen this information, but we were, of course, recognized internally at our Quality and Sharing Day. These are just some of the examples of how Atrium has been recognized for the multidisciplinary work that we are doing to reduce readmissions and improve quality of care.
Okay, we would like to thank Ruth and Dr. Murphy for joining us today and sharing their Davies stories sharing their Davies story on readmission. And we would like to remind our listeners where to go find the use case recordings for all our Davies winners this year, and that could be found at the HIMSS Davies website at hims.org/Davies. That's hims.org/Davies, and you can find that in information on how to apply for Davies. Again, thank you for listening, and have a good day.